or to welcome you all to this meeting. As we wait for a small technical hitch with the host, the moderator for the meeting, Ms. Irene Orgood, I would really like to just take this opportunity to thank you all. I can see that we are already almost 200 participants, and all the participants who have taken their time this morning to join this webinar. This webinar is a series of webinars that is looking at stewardship for blood transfusion services in Kenya. It is part of a 6-series webinar process. And over the 6 webinars, we will be discussing a number of issues relating to 1, rational use of blood, 2, policy issues and direction in terms of engineering the blood service. 3, we'll be discussing about quality management in blood transfusion services. We will have a session where we will also be discussing issues related to hemovigilance. And finally, we shall also discuss about accountability in the context of costing and valuing blood, as well as the blood management information system, a track and trace system for Kenya. This is part of what we have been doing over the last 2 weeks or over the last few years. And as we have been engaging this past year, and as we have been engaging, we want to really appreciate the support we have had from many of our different partners, the support from many of our different players, stakeholders, from professional institutions, from researchers. We also want to appreciate the support that we have had to be able to host this series. As we begin, I am very well aware that we may not all know the investments or the direction that has been done over the last year in the blood services. And I would like to invite you all to a series next week that will be a session next week at the same time that will be looking at where we are coming from and where we are going. But importantly, for this particular session, which is about appropriate and rational use of blood and blood products, I want to just note that we have expanded the capacity for processing of blood components to at least about 16 satellites, which are in 16 satellites and regional blood centers located in 16 different counties. And we are more than happy to be able to provide a schedule of where those are. This means that as healthcare workers, for the healthcare workers who are here, you can be able to request and make requisitions for blood and blood products. The other key item that I think is worth noting is that over the last 1 year, we have reduced our turnaround time by more than 200%, which means that when healthcare facilities make requisitions to the National Blood Transfusion Service, whether they are making requisitions to the regional blood centers or to the satellites, we expect that they will get it within 24 hours. I think Irene may have come online, but Irene, you will let me finalize the introduction, and then I will hand over the moderation to you. Finally, I just want to note that in terms of blood collections, one of the items and the biggest issue for healthcare workers is the availability of blood. I am encouraging that healthcare workers can make requisitions from the satellites and the regional centers near them. In the last 10 months, we have had the highest number of annual collections ever in Kenya, currently by the end of October at 273,000 units, of which about 257,000 units have been used by clients, by patients. But the important thing is how we become much more clear or we use products. So it is now my pleasure at this point to say that these are simply my opening remarks. We look forward to having all of you in the 6-part series that will be discussing about blood and blood products and blood transfusion services for this country. Our commitment as a service is to be able to ensure that we not only reform the service, but we provide the minimum need for this country, which is at least 500,000 units, and we are seeing ourselves well on our way. We are asking healthcare workers, especially those in transfusing facilities, to be able to actually make requisitions as may be needed. So with those many remarks, I would like to hand over this session. I would like Irene to confirm if she is online so that I can hand this over to her. I have made my opening remarks. I will not be needing to speak again except to answer questions as may be, and so you may progress the rest of the presentation. Irene Orgut, are you in?
Good morning, everyone. Morning, Dr. Nduku, I am in.
Please, you may go ahead and initiate your present and continue with the deliberations. Thank you.
Thank you so much, Dr. Nduku, and I want to really apologize for that technical hitch that has taken me around 10 minutes for me to join. Nevertheless, I want to welcome everyone and echo what Dr. Nduku has said, that we are having a stewardship for transfusion services webinar this morning, and I'm really glad you're coordinating this webinar series. Today, we have lined up a group of doctors and consultants who are going to help us throughout the webinar series. I would like to just find out if the following panelists are in-house before we proceed. Dr. Fatma Abdallah, kindly say hi. Dr. Fatma Abdallah.
Hi.
Okay. Okay, Dr. Kibet Shikuku, kindly say hi. Dr. Kibet Shikuku, can you hear me? Okay, Irene, Dr. Irene Zamu, kindly say hi.
Hi, everyone.
Okay, thank you so much, Daktari, for joining us. Dr. Jermaine Makori, are you in the house?
Yes, good morning.
Thank you so much. Good morning to you, Doc. Dr. Mwebia, are you with us? Dr. Mwebia from Embu, are you with us this morning? Okay, and finally, Dr. Shelmi Mude, are you with us?
Hi, good morning.
Good morning, Daktari. Good to have you. So members and all the participants, I want to go straight to the presentation of the day by Dr. Fatma Abdallah. Dr. Fatma Abdallah is a hematologist at KNH and is a lead consultant in the documentation and policies in appropriate use of blood and blood components. She has been a mentor to many at KNBTS and in the country ecosystem, and I want to welcome her to take over as the speaker of the day. So welcome, Dr. Fatma Abdallah. Kindly, you can share your screen and take over for the next 30 minutes. Welcome. Dr. Fatma?
Hello, I'm trying to open my video, but it says I can't start my video because the host has stopped it. Can you hear me, Irene?
I can hear you well. I can hear you well, Daktari.
Okay, it's because my video had been stopped. Okay, now I see I've been allowed. Okay, let me now open the video and oh dear me. Okay, I'm having a small technical hitch. I've opened the video, but the camera seems to not to be showing my face. Okay, I'm having a challenge that's very close to my heart, and that is the promoting rational and appropriate use of blood and blood components. So to my scope, I have 4 main topics or subsections I'm going to discuss. I'll give an overview on the updated guidelines on appropriate and rational use of blood and blood components.
Dr. Abdallah,
Yes.
can you put your slides on a viewer mode, on a slide mode?
Okay. 1 minute. I need to go to slideshow, yeah? Okay, do you want me to go from the beginning? All right. Okay, is that better?
That's okay now.
Good, all right. So we are going to discuss stewardship for transfusion, and I'm going to focus on promoting rational and appropriate use of blood and blood components. And my scope is divided into 4 parts. 1, overview on the updated guidelines on appropriate and rational use of blood and blood components, the effects of irrational or inappropriate use of blood and blood components. I'll give case studies depending on the time for rational and irrational blood and blood component use. And then finally, I will end by giving a general guidance for rational and appropriate transfusion use. So I'll start with overview on the updated guidelines on appropriate and rational use of blood and blood products. These guidelines were recently reviewed and updated September this year, actually. Why? Because transfusion services in Kenya have grown, both in scope and sophistication. The Kenya National Blood Transfusion Tissue and the Human Organ Transplant Service, which is what it's known now, is now well established and has made tremendous progress in availability of blood, blood components, and blood products throughout the country. The service is progressively working to diversify and introduce newer range of components so that they are available to the clinician when needed. So these guidelines are designed in a more expanded form to assist and guide healthcare workers in the prescription and monitoring of blood transfusions. The hospital transfusion committees have been retained in the guidelines, and the section has also been expanded to give more guidance, because institutional avenues for the implementation of these guidelines requires the existence of these HTCs. Experience gain has shown that HTCs play a critical role, not only in implementing these guidelines, but more importantly, in conducting audits on blood components, and blood products, as well as the monitoring the safety of our patients, which is really what we are all focused on. Now, the review of these guidelines has benefited greatly in contributions from various experts, professionals, as well as experiences gained by the space over the years. So healthcare workers will find them very useful and will endeavor to implement them easily. Now, the overall aim of these guidelines is to ensure that the scarce blood resources are used appropriately and rationally, and more importantly, that transfusions remain safe and efficacious. Now, sections that have been added that were not there in the previous guidelines are, to name just a few, are one, the selection order of blood for cross-match, as well as the question of whether to screen for autologous blood. 2, calculations of the transfusion rate when the clinicians in the wards are monitoring this transfusion, as well as the criteria for donation of autologous transfusions. The goals, number 3, of transfusion in different situations, especially in those patients that consume a lot of blood and blood components, example, sickle cell disease, cardiac patients, as well as cancer patients. Number 4, what are the triggers for transfusing 1 unit of blood, as well as the definition and causes of platelet refractoriness. Number 5, what to do with unutilized autologous blood. Do we throw it away? Do we use it for another patient? And guidelines on how to screen for transfusion reactions. A step-by-step process has been put there so that the clinician is not lost as to what to do. Number 6, indications of warming blood where necessary, because we've seen in clinical practice that most of us just warm blood for everyone, but there are special indications for this, and these have been included. And there are special blood components that were not included before and tackled, and now we have them in the new guidelines. And lastly, but not least, apheresis has become very common in our clinical practices now, and so it has been included, and its available components. So now I'd like to move to the next section on what are the effects of irrational or inappropriate use of blood and blood components. There are several consequences that we must keep in mind all the time. As clinicians, we shouldn't always just rush to request for group and cross-match the minute we see pallor in a patient. Let's consider all these and put these in perspectives before we make a decision whether we do need to transfuse that patient. So the first thing that happens is alloimmunization of patients. We usually look at and only remember that red cells have blood groups, they have antigens on their surface, but we have to remember white cells also have antigens on their surface, so do platelets. And all these, because we don't group for them, that the patient is being exposed to them. And it's a protein, it's a foreign protein. If the patient doesn't have that protein, then the immune system is going to be alerted and is going to develop antibodies. We will see an increased incidence of TTIs, though the transfusion service in this country is doing an excellent job of screening for our blood and blood components and making sure that these TTIs are at the minimum acceptable in the international reviews, but we know that it's still possible. So the next thing also, we would begin to see an increase in incidences of transfusion reactions. We may not see them. Many of us don't see them in clinical practice because perhaps we don't monitor for them. Many times when a patient, once a patient has been transfused, we usually just are happy to quickly discharge them, but we don't follow up and do the necessary to find out, did they have a delayed transfusion reaction if none happened while they were in the ward or during the transfusion process. And in consequences, we also must remember we may also see an increased loss of life, because some of the reactions are immediate and they are fatal, like the anaphylactic reaction that can happen during a transfusion, or the acute immediate hemolytic transfusion reaction. If it is missed, this may end up with loss of life. We may also see an increase in maternal mortality rate, because the 33% of the causes of maternal mortality rate is really bleeding or hemorrhage, and hence the need for blood and blood components. So if we are misusing them inappropriately, or we're using them inappropriately in other clinical situations, when now a mother walks in at 3 a.m. With PPH or APH, we may then have a shortage and end up losing that mother. It also results in increased financial burden to the family. As we know, you cannot transfuse, you cannot prescribe transfusion and let the patient go home with it. They have to be admitted in the ward and stay there until their blood group is found and they get the correct blood, and then they are transfused. So that's an increased financial burden to the family. And this also translates to an increase in the overall national health budget, especially because, as we know, our health in this country is partly subsidized by the government, and especially in our government facilities. So this will also result in an increased health budget. There may also be opportunity losses for the workforce in the nation. When you've admitted somebody who could have gone home maybe on hematinics, but you've admitted them for transfusion, they are not there to work. And so that's lost opportunity. This also results in financial losses to the employers, whether they're whether government or private, the private sector. It also means when we use blood components inappropriately, we waste the blood and these components. And this is a very scarce resource, as we all know. And so we really have to ask ourselves, does the patient really need blood? Will this patient die if they don't get transfused? And if I must transfuse, then which component is missing in this patient? What does this patient need? And therefore give only the component required instead of using whole blood. So as we continue, if we continue inappropriate use, we will worsen the blood shortages and make life difficult, not just for the healthcare workers, but even for the patients and the family, who get very frustrated every time they come and ask, has my patient been transfused? Say, no, we are still waiting. Then another consequence is we will then not have or we lack national reserves of blood stock. This is very important to have, so that when we have a calamity, major accident, we should be able to have some reserve to quickly be mobilized to the scene so that they can save lives. It may also encourage the blood black market, where when the shortages are very severe, some people will then decide they want to be paid to donate blood for a relative who maybe doesn't have donors because the family is in another town and they've been admitted in a hospital far away. Then also, it means that when we are misusing whole blood, we will not have available plasma for manufacturing reagents, kits, and blood products. Because if we usually separate the whole blood into components, we end up with a lot of extra plasma. Some of it will be used, but usually in the countries that have done this and have practiced this for many years, they've realized that they end up with an excess plasma, which can then be channeled for that country to manufacture their own reagents, to manufacture their own kits and products. So because we don't do that, it means that we are forced then to import these reagents and blood products and the kits. Otherwise, they could easily be manufactured within the country, provide employment for people, and make them affordable for the mwananchi. That means then the country will be spending more foreign exchange on the importation of these reagents, kits, and blood products. I just touched on a few for the sake of time, but maybe we can discuss more during the question and answer session. So I'll move now to the next section on case studies for the rational and irrational blood and component use. I have several. Irene, maybe you will help me when I've finished with the second one. You'll let me know if I still have time, because I still have the last section to discuss the guidelines. How should blood and blood components be used rationally and appropriately, which is really very important in the crux of this my presentation. So you'll alert me. So let me go to the
Doc, you have 8 minutes. You have 8 minutes.
8 minutes. Wow. Okay. Let me see how we will do this. Okay. So case one, NMM, 6-year-old male, newly diagnosed with ALL, acute lymphoblastic leukemia, was admitted with dyspnea, generalized lymphadenopathy, and bleeding gums. His hemoglobin was 5.4. He had a high WBC count of 69, and his platelet was low at 16. So the clinician in the ward sent the sample for group in cross-match and requested for 3 pediatric units of fresh whole blood. And she really emphasized the fresh. Okay. So the transfusion lab released what she had requested, and the patient was transfused. But what happened after the transfusion, the clinician noted that the dyspnea was persisting and the bleeding gums were still persisting. So the hemogram revealed that the hemoglobin was just 6.4 in spite of the 3 units. The WBC had increased to 91 and the platelet had even dropped to 10. So the clinician was very surprised at these results, since they thought that surely fresh whole blood has both red cells and platelets. So they decided to consult the hematologist to find out what is the problem, and so what are the issues here and the consequences. Let me proceed to them. Now, whole blood, let's remember, whole blood has an average hematocrit of about 36. Hence, is poor at boosting hemoglobin because of the excess plasma that's found in the whole blood. Okay, that's why the hemoglobin only moved to 6.4. We must also remember whole blood is stored in the fridge and therefore has no viable platelets. If any of you remember, if you ask for platelets require to be kept at room temperature, usually between 20 to 24 degrees centigrade, and they need to be continuously agitated. So when whole blood is sitting still in the fridge, there are no platelets at whole blood. That's why the patient didn't improve. Now, what did this result in? It resulted in delayed initiation of the acute ALL treatment for this boy. And we know, and many studies have shown that delayed treatment of malignancies worsens the prognosis. In the process, he also needed more transfusion of now the blood components, which were advised now by the hematologist. So the hematologist said, no, you have to request for packed red blood cells separately from platelets, because the two, the storage conditions for the two are different. And if the purpose is to boost the hemoglobin, then the component to do that is really packed red cells. And to boost platelets, you need platelet concentrate. What this meant also was that this young boy was already had an increased exposure to foreign antigens for the 3 units of whole blood that he got. And therefore, he's at a higher risk of developing transfusion reaction and of getting TTIs, the transfusion transmitted infections. It means that this patient will have to wait for the processing of these components, depending on the facility that he's admitted in, how far the nearest regional blood bank of the Kenya Blood Bank Service is. This means an increased hospital stay and therefore an increased hospital bill. And all of this will result in increased parental and family anxiety and stress. Let me now move to the second case. LWG is a 34-year-old female, para 2+0. She developed PPH, postpartum hemorrhage, and was referred to the nearest sub-county hospital from the health center where she had just delivered. The MO on call at the sub-county hospital immediately admits and rushes her to theater for emergency hysterectomy. The MO notes that the patient was paper white, had profuse PV bleeding, the blood pressure was 90/50 with a pulse of 109, and the patient was semi-conscious. So the MO requests the lab for urgent, uncross-matched 10 units of whole fresh blood and fixes a line with normal saline while she waits for the blood. Unfortunately, the lab quickly calls theater and says there is no blood available in that facility at that time, and they are planning to get it from the regional blood bank 2 hours away. So what does the MO do in those 2 hours? The MO decides to call the consultant for further advice, and the consultant directs her to do 2 things. 1, to fix 2 or 3 more IV lines and run normal saline speedily, to open the valve so that the normal saline runs in quickly, and to ask the lab if they don't have blood, could they be having fresh frozen plasma, FFPs, or cryoprecipitate, while requesting them to quickly go and bring the packed red cells and platelets from the regional blood bank. So the MO follows the directions very quickly, and notices that after 20 minutes of now, remember now the patient has more lines with more normal saline going in, the blood pressure has improved slightly to 90/50, the pulse also slight improvement to 94, though the PV bleeding persists. So meanwhile, the lab was preparing and thawing the FFPs and grouping the patient. So the lab reports that the patient's blood group is B positive, and that they only have 3 available FFPs, fresh frozen plasmas, all of which are blood group AB positive. With consultation, the MO says just thaw them and bring those FFPs. They can still be used for this patient. So the patient was quickly transfused, 2 of the thawed FFPs, and was transfused as FFPs. And the third FFPs, the MO was directed to request them to process them as cryoprecipitate. Then after the cryoprecipitate was thawed, it was quickly sent to theater. The MO transfused it, and now the MO notices that the blood pressure improved to 160, the pulse also improved to 82, and the PV bleeding had reduced remarkably. The patient was stabilized and wheeled back to the ward to await the components coming from the regional bank. These components arrived in 5 hours later. Remember, it was 2 hours going and 2 hours coming, and then the cross match. And therefore, 5 hours later, the first unit of platelets and the B positive PAC red blood cells were started. Sorry, I didn't get time to show you those, but we will continue. So what are the consequences of this experience? One, most important and very, very critical for all of us, one less maternal mortality death. We saved one mother. Two, the family avoided a catastrophe. Three, 2 children were prevented from being orphaned. 4, the MO managed to save another uterus for possible future use. Who knows, the mother may have, could be wanting more children. Something we forget, number 5, is that we healthcare workers really go through a lot of emotional and psychological pain when we lose a patient. So that facility, the staff of that facility, both in theater, labor ward, and labor ward, was saved. The emotion and psychological well-being was boosted by saving that mother's life. 6, the MO and theater staff learned how to manage PPH successfully. They will not forget that experience, and the next time a mother is wheeled in with PPH, they will know how to go about it, whether they can find a consultant or not. And finally, to name just a few of the consequences, we prevented wastage of 10 units of whole blood. Remember, that's what the MO had ordered, and that's what most of us order. We want whole blood because we know the patient is bleeding and we want to put it in as quickly as possible. But instead, we used fewer components and we still saved this mother's life. Now, I can see that my time is running out, so allow me to go to my 4th section where I would like to give general guidance.
Dr. Abdallah. Dr. Abdallah, time is over.
Yeah.
Time is
Can I
over.
have 1 minute? I just have 2-3 slides.
Okay, kindly.
Okay, so I'll go this quickly for you. So, how do you decide to transfuse? The decision must be based on both hematologic evaluation of the patient, the clinical state of the patient, as well as the patient's risk for developing complications of inadequate tissue oxygen delivery. So the considerations and guidelines, usually for patients whose hemoglobin is more than 10, you don't need to transfuse, but if it is between 5 and 10, that decision is determined by the additional clinical status of that patient. If the hemoglobin is less than 5, you should plan for transfusion. Notice I say plan, but you can do something in the meantime. We'll come to it. But for neonates, the guidelines are slightly different. Any neonate with a hemoglobin of less than 7 requires transfusion. If it is less than 8 and the neonate has apnea, tachycardia, or tachypnea, you'll transfuse. But if it is less than 12, if in severe respiratory distress or having heart disease, you will transfuse. What are the other considerations? Hemorrhage. And this is where many of us get confused. The guidelines state, when blood loss is less than 15% and there are minimal symptoms, don't transfuse. Start IV fluids if necessary. When the blood loss is 50 to 30% and there's tachycardia, you still don't need to transfuse. You can manage it with other things. But when the blood loss is 30 to 40% and there are signs of shock, start with a volume expander. A simply normal saline is a very good volume expander. It is cheap, very effective, and available throughout the country, even in the remotest facilities. And then decide what to do next as you monitor the patient's vital signs. But if the blood loss is more than 40% and the patient is in severe shock, you start with a volume expander as you wait for transfusion. Remember, where if possible, you should use cross-match blood and avoid using uncross-match blood whenever possible. And there are other considerations. Many of us usually will transfuse patients who are going for surgery. Why? Because we didn't check their hemoglobin when we first clocked them as they came to the clinic. We wait until the day of admission because we tell them to wait for a bed. Then the day before the surgery, when the bed is available, when we admit them, then we send them for HB and UNEs, and we get surprised when the hemoglobin is less than 10, and we know the anesthetist will not agree to put them under GA without that. So if we are to monitor or screen our patient, do a full hemogram the first time we see a patient in our clinics, we will be able to get the mild to moderate anemias that can be managed outpatiently at home while the patient is waiting for availability of bed in the surgical unit. We should also practice autologous transfusion if the patient's hemoglobin comes to be good, and ensure that we reduce blood losses intraoperatively or reusing blood loss in cavities, like in ectopic pregnancies. I'll just move to the next because of time. And for chronic anemia, we should only use blood to relieve the clinical signs of congestive cardiac failure and or respiratory distress, just for hemodynamic stability. Otherwise, we should use oral hematinics, or we can use parenteral erythropoietin if time is a factor, together with the oral hematinics to boost the hemoglobin quickly. And if we must transfuse, then let's only use packed red cells and not whole blood. But let us remember that anemia is not a disease. It is a symptom of something else. We must investigate any patient coming with anemia. Let's not just transfuse and send them home. Then they come back again, we transfuse and send them home. Until somebody decides after several admissions that, oh, why is this patient being transfused so many times? And instead, sometimes of investigating, we refer to Kenyatta Hospital Hematology Clinic for further review. And I think I'll stop there. Sorry, Irene. I hope the extra time I took is not going to interfere with the others. Thank you very much.
Thank you so much, Dr. Abdallah, for that insight. Participants, you are going to have time for the question and answers. If you have any question for Dr. Abdallah, kindly make sure you chat it somewhere, and then Dr. Abdallah is going to respond in due course. Allow me now to proceed and present 10 slides from KNBTS M&E department. I don't know if we have Monari. Do we have Monari in the house? Mr. Monari? Hello? Can you hear me?
I think kindly proceed. Thank you.
Okay. Dr. Abdallah, can you pull down your presentation, please, so that I can put mine? Dr. Abdallah?
Okay.
Okay. Mr. Monari from M&E KNBTS, can you hear me? Mr. Monari? Okay, meanwhile, I want to welcome Dr. Shelmith Mude from Maua Methodist Hospital as one of our discussants, to react to the presentation of Dr. Abdallah. Thank you so much. Welcome, Dr. Shelmi.
Okay, good morning, everyone. Can you hear me?
No.
Good morning, everyone. Can you hear me?
Yes, we can.
Oh, thank you for the opportunity to react. Thank you, Dr. Abdallah, for the good presentation. Thank you for summarizing the points that you had. I think some take-home points from the discussion. The hospital transfusion committees as central in implementing guidelines. I don't know how many of our hospitals actually have functional transfusion committees. These are critical components, as you say, but I don't think we have many of our hospitals with those. The other thing that I have picked up would be the goals of transfusion that vary. So for the neonates, for the cardiac patients, and just picking up that the pala is not an indication for transfusion. I think in many of our institutions, what we find is once a patient has been declared pale, people quickly rush for blood. The other thing is autologous transfusions. I think this is important for me as a surgeon. So many times you have either a trauma patient who is bleeding, or you have a case that you've done and the patient has bled significantly. That may be something that is key to reducing our transfusion rate, especially intra-op for our patients. Then the other thing is investigating anemias. Most of the times when people see anemias, they are quick to transfuse, and only later, as you say, do they request for further investigations. I think that should be something that's emphasized, especially in our institutions that are in the rural setting. So those are my reactions, and thank you all.
Okay, thank you so much, Dr. Shelmi. Allow me now to carry out a screen share of some few slides concerning the M&E monthly report from KNBTS. Can you hear me? Dr. Shelmi, can you hear me?
Yes, I can.
Okay,
I can.
Okay, let me proceed. Colleagues, I want to share the July-September 2021 Q1 M&E report from KNBTS. And as you can see, KNBTS establishment has 48 sites that are busy collecting blood for the whole country. These 48 sites, we have almost 8 sites that are not active, but we hope to bring them on board by the end of this year. But most of them, almost 40, have been collecting sites. So you can see almost 47 counties are represented here by the KNBTS satellites and regional centers. We are almost everywhere in the whole country. So this is KNBTS network. And as you can see, these are the collections for our last quarter. We can see the blood that was collected in KNBTS last quarter was 47,221 whole blood. And those collected in transfusing facilities, these are the county hospitals, the private hospitals that are not within the network of KNBTS, was 6,845. So we had a total of 54,066 units that were collected in KNBTS as a whole. Among these, we can see clearly that 25,671 units were converted into packed red cells, which is a great milestone because this is part of the #1 component in the country. 18,424 were issued within KNBTS establishments as whole blood, translating to 29%. PID packs, these are the units that have been prepared in the laboratory into smaller sizes from whole blood, and we can see it accounted for 5% of our preparations. The platelet concentrates accounted for 4%, the FFPs accounted for 5%, FP 24 hours, this is plasma that is frozen within 24 hours of collection, accounted for 5%. And the cryoprecipitate has never been prepared. And if it was prepared, it was discarded because it has remained a component that no one has ever requested for in the whole country.
Wow.
As we can see here, these are the issuance, what was issued in the last quarter by KNBTS. We can see GOK took a total of 35,560 units, followed by private facilities in the whole country that were able to be issued with 10,350 units, followed by faith-based stroke mission hospitals that were issued with 3,978, and RBTCs and satellites. Occasionally, we are able to exchange blood amongst ourselves and blood components, and it accounted for 748 units. A figure that follows here is, we can see that whole blood, which was issued, was 15,880, and we can see adult packed red cells being the product of choice by our clinicians, meaning that this is the product that is being requested by the clinicians, and it becomes the product of choice for the country at the moment. Feedbacks, still we are not requesting, or rather maybe the preparation is not being tackled well, but somehow we are able to have 2,482. And then the platelets, we can see 2,946, and fresh frozen plasma at 2,808. Cryo was neither issued or was neither requested. And this is a question for our clinicians in the country. The question is, are these patients who need this factor 13 that is found in cryoprecipitate we don't have these patients in the country, or we are not aware that this product can be prepared in KNBTS. So this is one of the take-home assignment for all our clinicians who have joined us this morning. This is whole blood. It will always come to you 450 mLs, 405 to 495 mLs, that is plus or minus 10%. And there is no preparation that takes place in KNBTS or in the laboratory component lab to this component. And we know we have patients who require whole blood, though we are fighting hard to make sure we get this blood, this product, or rather this component out of the shelf, because we want to ensure that we move into component therapy as a country. We have whole adult packed red cells that will always receive in 280 to 336 mLs. It's slightly smaller than whole blood. It is not like whole blood because we have removed the plasma and we have gone ahead and added the artificial plasma in order to make sure that the preservation is taken care of. This product will always receive this component with an expiry date of 35 days or 42 days, depending on the preparation. But we will always write to you, you will always see the expiry date. And this will show you that it is under additive solution, that is SAGEM, or it is under CPDA1, that is if it's 35 days. We'll always have this product circulating in KNBTS network, blood establishments, and in the hospitals as pediatric packs. It is 100 to 125 mLs. This is because Dr. Irene Zamo and the team who are pediatricians, it is easier for you to scale down 40 mLs from 100 ml pack than to scale down for 40 mLs from a 450 ml whole blood. So this pack, we encourage most of the clinicians who are dealing with the peds to please request for this product, which is available in KNBTS. We have this product that is also in KNBTS networks. They are fresh frozen plasma, 250 mLs, and they contain factor 8. And you will also have another one that is called FP 24 hours. We will always alert you whenever we give you an FP 24 hours because it is not the same as FFP. FFP is very rich in all the clotting factors except platelets, but when we give you FP 24 hours, it means we have given you a product that is a half a dose of an FFP. All of them will keep on circulating in our establishment as we up our game and ensure that we end up having FFP only as the sole component in KNBTS and the ecosystem in Kenya. This product that is here is called platelet concentrates. The first two, which you can see, are prepared in the laboratory, and they exist in 40 to 70 mLs. We issue them in 40 to 70 mLs, and they are supposed to be under constant agitation for 5 days. But the next one here is apheretic platelets, which we have just introduced as one of the products in the country. We have 4 apheresis machines in Kenya. We have 1 in Nairobi, 1 in Nakuru, 1 in Kisumu, and 1 in Eldoret. So those clinicians who are in those areas, all the 4 RBTCs which I have mentioned, will always receive these apheretic platelets, and they are very rich. They contain almost 5 platelets of the ordinary ones which we prepare in the laboratory. So both of them are platelets. The difference is only the volume. The apheresis platelets are always 200 ml, not compared to the other ones, which are 40 to 70 ml. Lastly, we have our cryoprecipitate, the very rarest. We don't want to get rid of cryo as a country, but rather we would like to challenge our clinicians to please request for this product. I believe those patients are out there. I believe instead of buying the von Willebrand factors to treat these patients, rather we use this cryo, which is easy and it's cheap for us to have. Thank you so much, and allow me to stop the sharing and move on with the program. That is all I had from the presentation from KNBTS on behalf of the what is circulating. And you can see we have so many products that are circulating in KNBTS ecosystem. So can you hear me, Dr. Shelmy?
I can hear you well.
Okay, thank you so much. So having finished there, time is not on our side. I want to move very fast to welcome our discussants. As I introduced that we have a number of discussants in the house already, Dr. Shelmy has already given out a presentation or inputs. Allow me to welcome Dr. Mwebia, who is from Tiara Sub-County Hospital in Embu, to give us, to shed some light on the 2 presentations. Remember, we have had a presentation from Dr. Abdallah, and also I've done a short presentation on the different types of components circulating in Kenya under the Kenya National Blood Transfusion Service. Welcome, Dr. Mwebia.
Okay, good morning, everyone, and thank you, Irene, for this opportunity. I'd like to make a remark from the first presentation by Dr. Abdallah. I like the emphasis that she put on, again, the role of hospital transfusion committees. These come in very handy in coordinating transfusion services within the hospital. And at my hospital, we constituted one earlier this year, which has come in very handy in these issues of transfusion. And actually, one of the recommendations that we had come up with in one of our meetings was to allow for blood exchange. Whenever we collect blood at the facility from various donors, the practice has been to send a sample to the regional blood transfusion center for screening, and then we use it whole at the facility. But it's coming out clear that we need to use blood components as opposed to whole blood because of all the benefits that have been alluded, that we get to save more lives by using these components, and just 1 pint can be used by more patients. So I think this is a recommendation that can be adapted across the board. And the other thing that came out clearly was the critical role that blood plays, especially in prevention of maternal mortalities. And therefore, it's critical for us to use the products that we have rationally. And I like the emphasis that she put on the various classes of hemorrhage, that we need to transfuse, especially in hemorrhage class 3, when in consideration, especially for patients who have other medical conditions. And transfusion is mainly indicated in class 4 of hemorrhage. And I think in our daily practice, we've seen patients either in class 1 or class 2 being transfused, and mainly because of either misinformation or the need to practice defensive medicine, basically to cover ourselves. But with clear guidance, then this will promote rational use of our blood products. And we know that with every inappropriate transfusion that is done, there's a patient somewhere who is denied a chance to survive due to inavailability of the same. So, and also due to the unnecessary exposure to the side effects of the transfusion that Dr. Abdallah has alluded to. Those would be my comments for now. Thank you for the opportunity.
Thank you so much, Dr. Winnie from Embu. That input. I am very sure our participants who are watching us across the country will have questions concerning these presentations. So just be on standby. I will engage you later. Allow me now to welcome Dr. Makori. Dr. Makori, are you in the house? Dr. Makori?
Yes, I'm in the house.
Okay, kindly give us some inputs and share your thoughts on the two presentations and also some way forward.
Thank you for this opportunity. I would like to thank Dr. Abdallah. She's a champion as far as blood transfusion is concerned in the country. And I believe this is not enough time for her to talk about everything, but hopefully the message will pass through. Sorry, there is some noise in the background. I'm surprised by the variety of products that are offered by KNBTS, but also I feel proud that the packed red blood cells are the most requested products because it shows that we're moving away from using whole blood. Whole blood has its own challenges, and most of the time it is not indicated. What we need is packed red blood cells. Then the reason why people don't order for cryoprecipitate is not very clear to me, because this cryoprecipitate still have a role in the management of some conditions. As she said, the coagulopathies such as von Willebrand disease, but also hemophilia. But also, we know that we are doing a lot of, quite a number of massive transfusion, and cryoprecipitate use is indicated when you're managing a massive transfusion. And as we talk about massive transfusion, I have to emphasize on the fact that requests for uncross-matched blood are misguided, if I would say, because when you request for uncross-matched blood, it is only the first unit that is uncross-matched. And like in KNH, our guidelines, once technology gives you uncross-matched unit, they are supposed to stop everything they're doing and cross-match it. Then they will call and tell you if it is been cross-matched with the patient unit sample or not, so that you stop. So it is only the first unit that is uncross-matched. So there is no room for requesting 4 units, 8 units uncross-matched. That has no role in medicine. As much as we're practicing defensive medicine, as it was called, we should also do evidence-based medicine. Those would be my comments. And I hope that in the future presentations, more of these challenges will be elaborated so that people get guided. Thank you.
Yay, thank you so much, Dr. Makori. We promise to engage you more in the near future so that we can keep on making sure that the blood ecosystem is healthy in Kenya. Thank you so much for your inputs, and I'm very sure you are going to work with the other group of clinicians to ensure we try and raise the graph of cryoprecipitate in Kenya as a country. Thank you so much. Now allow me to welcome Dr. Irene Nzamo from KNH. She's a pediatrician, so that she can give us a few of remarks too, like the other colleagues. Irene, Dr. Irene? Dr.
Yes,
Irene.
Yes, Irene, I'm here. Thank you so much for the opportunity. And I just want to concur with my previous colleagues who have spoken, thanking Dr. Abdallah for a wonderful presentation, and even thanking you, Irene Ogut, also for the presentation of the components and the products we have. And as a pediatrician, I'm happy because children and neonates have been very well captured and very well represented, such that as we continue spreading the message on appropriate use of blood and the components, We remember that neonates and children are different, and even the way we prescribe their blood and their blood components is also different, and the rates of how we let it flow in the children, the flow rates, the prescription, how we monitor the little ones is also a bit different. So I'm really glad about this guideline, and I know it will improve the outcomes of our children out there. Now, maybe one comment I'll make is that when it comes to pediatrics, when we are treating their anemia, let's also remember to look at the baby in totality. Let's not forget about malaria. So the issue of telling them about mosquito nets and treating malaria, even when you're trying to transfuse that very severely anemic child. And even the issues of deworming children, you know, the helminths that they have, and we have to also deworm them and do nutritional counseling for the children, issues of iron and the diet they are taking. So we look at the babies in totality. And then the other issue I would also like to make a comment about is, as a clinician, is just to say that we shall try as much as possible to increase the usage of cryoprecipitate. Like Dr. Makori has said, the patients are there. I work in Kenyatta, the patients are there. Fibrinogen deficiency, we've seen those patients. Factor 13 deficiencies are there. Hemophilia, these patients are there. So it is for us to sensitize ourselves a bit more and start requesting for cryo a bit more. So I'm very glad to be here, and I know this message will go widely about the appropriate use of blood, and I'm happy that children and neonates have been protected in this guideline. Thank you very much.
Thank you so much, Dr. Irene. I'm glad to hear that you're going to work out with the team of our consultants in KNH to make sure that those rare products are not rare, but the patients are there, so that we can be able to save our fellow Kenyans. Asante sana. Colleagues, I want to welcome questions now. I know most of us are tuned in, are zoomed in from the whole country. I can see we have a number of participants, close to 400. Kindly, if you have a burning question to the first presenter, that is Dr. Fatma Abdallah, and also to the products team in KNBTS components team, led by Dr. Evelyn Chege, who is also in the house. Kindly bring your questions so that we can be able to answer those questions. It's time for questions and answers from anyone, anywhere. Kindly, let me have the first question for the team.
Irene, if you allow me, I've seen a few questions on the Q&A box. While we wait for people to ask, maybe I can start by responding to some of those. Is that okay?
Okay, Dr. Fatma, go ahead.
Okay. Somebody asked, can genes be transferred to the new host? Assume they mean during transfusion. I think this is a very good question. Yes, it's possible not to be transferred as genes, but remember when in the peripheral blood, which is what we collect from donors to then finally transfuse to recipients, there are always some few circulating stem cells. These stem cells have that capacity. They carry the genes and they have the capacity to, when they now, if they happen to have gone into that donated blood and are transfused into the donor, they do have the capacity to get into the donor. And then what happens when they get into the donor? You can't really transfer genes so that, for example, now the recipient starts looking like the donor. But what can happen is, first of all, the immune system usually is very alert in the recipient, unless the recipient is immunocompromised. So usually the immune system will look out for these foreign cells, and if they are recognized, they're usually destroyed. But in some of them, if they are not destroyed, you may then transfer. For example, if the donor didn't know and has started having malignancies like we have, for example, we have a situation, a condition called polycythemia rubra vera, or primary proliferative polycythemia, where the patient produces a lot of blood, and usually part of the treatment is to get that patient to donate blood. Now, we don't use that blood to give to a recipient because we are concerned and worried that maybe some of those stem cells from that person who has polycythemia, they may enter, when they enter the recipient's circulation, they may escape the immune system and go and lodge in the recipient's bone marrow, and maybe then the patient would get the polycythemia. So we are not transferring genes, but rather we could transfer malignant cells, though the risk is very low, but there is that possibility. That's why we will not use blood from a patient with polycythemia, since that's a stem cell abnormality, and for that reason, but not genes. That's not possible to do that. Do I continue, Irene, to the next one?
Continue.
Okay. The next question is asking, there's a considerable reluctance for hematology consultation when it comes to transfusion needs, as the case study example that I gave. Do the new guidelines emphasize as to when this should be done? Absolutely. Thank you for asking that very good question. The new guidelines have put into place when you should refer or when you should consult a hematologist. For a while, we had very few hematologists in the country, but now many have been trained and we have them, plenty of them. So it shouldn't be difficult for somebody to get a hematologist to consult when they require advice on transfusion. But at the end of the day, really, it is you and how comfortable you feel. If you don't feel comfortable, you're welcome to seek for advice, and the hematologist will be very happy to give you their knowledge and skills. Next question says that during a whole blood transfusion, the packed red cells tend to separate from the plasma and settle at the bottom, I assume he means. Can the plasma be harvested and sent to KNBTS centers for future use? Very good question, but this should be done before the transfusion. Why? Because once you have removed the whole blood from the fridge and you've started your transfusion, the plasma is now getting warmed up, and when it is warming to the environment temperatures as the transfusion is going on, that the goodness or the quality of that plasma considerably reduces. We tend to lose the coagulation factors that are unstable. They all disappear and disintegrate, and therefore finally, if we are to wait until now the transfusion finished, when all the red cells have gone in and you're left with plasma, for the plasma to be returned back to the KNBTS, it may not be very useful plasma for any patient who will get it. Number one. And the second reason why we shouldn't do that is that remember now it has become an open system. Once you start transfusion, it's an open system, and there is a possibility of infection getting into that unit, and you don't want to transfuse somebody with infected plasma. So the practice, as Irene has very clearly explained, is that as soon as the whole blood has been donated, it is immediately processed. The sooner it is processed, and the recommendations are within 4 hours, it is processed and separated into plasma, packed cells, platelets, then the better the quality of those components that have come from that unit. Number one. Number two, also, those components can now be quickly put into their required storage conditions, because each of the different components require different storage conditions, different storage temperatures. So as soon as you're able to put that component into its storage condition, then you improve its viability and you also maintain its quality to be quite high. So that's why we don't wait. We do it fast, quickly. And then, of course, maybe you don't know that, yes, we do put them in the fridge, but for the fresh frozen plasma, for it to remain its goodness and for those unstable coagulation factors to be contained and to remain viable in that plasma has to be put quickly into the freezer. And the higher the temperature of that freezer, then actually the longer it can serve. For example, if we are to put that fresh frozen plasma into a -80 freezer, did you know that plasma can remain good and useful for a patient for up to 7 years? Food for thought. Do I continue, Irene? There's another one.
Yes, if you can see the question, please go ahead, Dr.
Yes. The next one, very good questions people are asking. Thank you, all of you who are asking these questions. They're helping me to discuss some things that I couldn't get in during my presentation. The next one says, considering the perennial blood and blood component shortage in Kenya, can we use incentives, both financial and non-financial, to get more people to donate more blood? Very good question. Well, according to the International Society of Blood Transfusion and American Blood Bank societies, financial incentives are not allowed. So we need to then use the non-financial ones, which some of the other developing countries, similar to Kenya, have done successfully and have been able to boost their blood donations from the citizens in that country to a level where they ended up with so much excess plasma that they were able to then set up a manufacturing unit in that country, and they make all their own products, reagents, even the screening kits for the TTIs that we use to screen our blood. They make everything themselves within the country. And they have used 9 financial incentives. If I may explain, I'll tell you the country, it's Thailand. And you know what they did? They told the citizens that if you donate more than 7 units, not to your auntie, uncle, or relative, you are just donating and not wanting to know who it's going to, and you're only donating not when your relatives and friends need it. You just walk into a blood bank and donate. So those who've donated more than 7 units get the opportunity to be invited to the King's Palace in Bangkok, and they get a certificate and they get a chance to be greeted by the king and get a certificate from the from the queen herself. And that has proved to be very, very, very beneficial. And the citizens they're all competing to be invited to the palace for such thing. So that has worked very, very well for them. And they no longer, they used to have the same problems as we did, shortages. They no longer have that. And even in the remotest part of Thailand, they are able to manufacture dry blood products, and it goes to those remote facilities, health centers and dispensaries where there are no fridges. But because it's a dry product, it doesn't need to sit on a fridge. And when the clinician gets a patient who needs it, the clinician just reconstitutes it and infuses it to the patient there and then. Okay, very good. Thank you. Okay, somebody asked, can individual blood resource change over time after frequent blood transfusion? Very good question. No, the rhesus, these are, it's genetic, you inherit from both your parents. It does not change. What can happen is that because of frequent blood transfusions, then that exposure to other antigens, because you're getting, every time you get the transfusion is from a different donor, and the different donor has different antigens compared to the ones you have or the ones you've been exposed to before, is that this patient gets exposed to so many different antigens and develops so many different antibodies that getting a good cross match can be a challenge. And I think that's what you mean, that it becomes difficult because the patient has too many antibodies that are interfering with the cross match. Now, this question, I think Irene or Dr. Irene Zamu or Dr. Jermaine Makori should answer. It asks, how common is the practice of autologous transfusion as KNH and peripheral hospitals? Maybe the other doctors can also answer. Give brief guidelines. So autologous transfusion, over to you, my discussants.
Thank you, Dr. Abdallah. I can answer that. Autologous blood transfusion, what is common in KNH are the pre-deposits. So if a patient is to undergo an elective surgery, they're allowed to come like 3 weeks before the nurse. It can even be like 6 weeks before and start depositing blood. So the units will be there and they will be reserved for them. But you have to understand that even if it is your own blood to be given to yourself, it has to fulfill the requirements from the Kenya National Blood Transfusion Services. So it should be TTI free. And that has been an issue because people feel if I'm HIV positive, I should be able to donate to myself. Then you don't give it to anyone else, you just give it to me. But it cannot be allowed in the clean fridge where now the units ready for transfusion are stored. If it is reactive, it should be discarded, even if you're donating to yourself. Then the collection during surgery are still a challenge. I'm talking about the ruptured ectopic pregnancy, ruptured spleen, where you could collect blood from the abdominal cavity, filter it, and reinfuse it. That one we are not doing at the moment because of a few challenges here and there, but the pre-deposits are being done. That is for the case of KNH.
Thank you so much, Dr. our discussant, for that.
So allow me to comment on behalf of the mission sector, and if there is anyone, with an addition they can add. I think in our setting, autologous transfusion has not been done. That is at Maua, the mission hospital. Even in Kijabe, because I did a brief time at Kijabe. So the experience there was, there is the children's hospital that does mainly pediatric orthopedics. They did some autologous transfusions, very rare cases, but that requires something called a cell saver. That's what they used to use, and that was, not commonly done. But in the mission setting, it's not a common practice.
Irene, if I may, thank you. Just to support what Dr. Makori has said, but it's a challenge to us to provide the figures and the data. So to respond to the person who has asked how common they are, we don't have the numbers on the fingertips right now, but it's something we can look into. Thank you.
This is Irene. This is Dr. Nduku. Can I make a few comments on one or two of the questions?
Yeah, welcome, Dr. Nduku. Karibu, Daktari.
Thank you very much, Irene, and the members, and thank you for your questions. I think I'll just take the
some of the ones like on donation. And yes, we are focusing on rethinking our, not just focusing on, but I've already started implementing new donation approaches. We are very well aware that we have relied on schools for a long time, and now we have moved on, saying from the premise that all these young people who leave school, they come out and go somewhere, whether it is tertiary institutions of any form, or it is in the informal sector, or into employment of some sort. And so therefore, we have started to focus on beginning to engage tertiary institutions, the universities, the vocational institutions, and various kinds of colleges. We've also started engagements or partnerships with various other bodies that have many people around and across the country, like the Border Association, a lot of young people. And we have then been having, as you've seen over time, different campaigns across the country that then bring these associations to leverage, to engage, and to mobilize their members. That is why currently, right now, as I started in my introductory remarks, over the last less than about 1 year, we have been able to raise more blood than we ever have as a country, being at 273,000 units by the end of October. We are in November. Yes, by the end of October. And so we will continue to have these partnerships, because that's the only way we can also start to build regular donors. The second thing is that obviously ICT, will be leveraging ICT. We are setting up and establishing the National Blood Management Information System, and we will use that system not only to provide donation, to reach out to our donors, but also be able to remind donors and so on and so forth of when it is that they should donate and so on. That way we can try and keep regular donors. Finally, on the question of the number of sites, whether we can ensure that we have more products. The expansion that we are doing is in two forms. The first one is new added sites. We are working with counties in the establishment of additional satellites. And the second expansion is added equipment for blood processing, so that we are decentralizing that as far as possible. Our vision is that what we have started in this year, having sites that are able to prepare components, we will be adding that, and it is our vision that all 47 counties would have access, or transfusion facilities would have access from their nearest satellite, let me put it that way, to be able to get components and components prepared. That will ensure that we are also enhancing access and availability to patients. The other issue that we are starting to think about is really how do we develop a stocking system where we can be able to say, to provide some sort of mechanism for transfusing, especially high volume facilities. What do you need to have in stock? What is the cold chain requirements for stocking the different blood types, and then provide a reallocation mechanism, especially for the rare blood groups and blood types using and products using the information system. Finally, we have there was the question on NHIF. It's a very interesting question because we are starting those deliberations. As you are aware, NHIF has been unbundling and reviewing the UHC package. We are engaging to ensure that a review of that package, actually, if I'm not wrong, there was a meeting either yesterday or today in which we are represented that has been looking at how we can ensure that this becomes part of the NHIF package. And the medical checkup is something that once we have this system, the ICT-based system, because we capture the data that we take as part of triage during when donors come in, that we will actually be able to put that information together into a form of report, so that your donor notification includes your medical report at the time when you receive it. Thank you.
Thank you so much. Thank you so much, Dr. Nduku, the head of KNBTS, for that input on NHIF and the other questions which were beyond us at our level. So allow me to give room to those people who have raised their hands. I can see someone has raised their hand. Kindly ask the question live. Just unmute and ask the question live. I can see several hands. Go ahead, I can see your hand. Joseph Sumba.
Irene, that's not possible because they are not panelists. So they can only.
Hello? Hello?
I can see you, Joseph Sumba. I can see your hand.
Oh, thank you so much. Thank you so much, all the speakers and presenters for that worthy presentation. My comment is about outpatient transfusion, because I think this is one area which puts pressure on all the systems, the health system, the care, the hospital system, and the family. What is your comment on, Dr. Abdallah especially, what's your comment on outpatient transfusions? Because I think this is something that should be looked at and embraced so that we ease the pressure on the system. Thank you.
Joseph, can you tell us where you are calling us from and which hospital?
Oh, thank you. My name is Dr. Sumba. I'm calling you from Kakamega.
Thank you so much. Dr. Abdallah, can you hear me? Dr. Abdallah?
Sure. Thank you, Dr. Sumba, for that question. Actually, several people have typed it in the Q&A section and I've answered. I think it's a very good thing to do. And as you say, it will reduce the burden on our wards, as well as the financial burden on the family and the country as a whole. But this requires special and organized daycare facility. So it's now for the facility to look into it. If they're doing a lot of transfusion, especially if the transfusions are on stable patients, for example, patients with cancer who just have anemia and are waiting for their next chemotherapy, other patients with chronic conditions who are stable but still require transfusion. All these can be done in daycare centers. And I know some facilities in the country have started it. And so each facility, and now this is where the role of the Hospital Transfusion Committee comes. That will fall under its umbrella to have a look at it, see if it's something viable for them in that facility. And then they will have to then organize a space for it, a good room. They will have to have a few, a clinician or two to be able to manage it. So those are all considerations that must go into it. But it is possible, just as in the oncology and in the treatment of cancers, we will have several facilities in the country where patients just walk in, get their chemotherapy, and in the evening, if they're stable, go back home. That way, it also allows a lot more patients to be managed at any one time. So I agree with you, and it's something we should embrace, but it needs to be planned for, well planned for, as I've agreed to the other people. I think there are two suggestions, Dr. Nduku Kilonzo. There are two people in the question and answer have given extra suggestions on what kind of non-financial incentives we can give to our donors. And maybe you can also have a look at them and see if they are viable to be included as an incentive for our donors. There's a question that Irene, maybe you can answer. Somebody's asking, what is the shelf life of platelets? I'll allow you to answer that one, I think.
Thank you so much, Dr. Abdallah. Can you hear me? Dr. Abdallah?
Yes, I can.
Yeah, the shelf life of platelets is 5 days at room temperature, that is 18 to 24 degrees centigrade at constant agitation. So we always store the platelets under constant agitation, that is 72 cycles per minute. That is a special device that we have currently in KNBTS, and encourage even the private and the mission hospitals to acquire this platelet agitator so that we can be able to store the platelets under constant agitation. So that is the shelf life of platelets. Let's go ahead with the question and answers. We can have 1 or 2 more questions answered. We still have time. Dr. Abdallah?
Yes, there's a question.
Are you seeing any question that is pending for the
yes,
team?
I do see.
We still have all the consultants in the house?
There's a question for the organizers of this webinar. The attendee is asking, what happened to the CPD points for attendees? Maybe the organizers can, but what I know is that when you usually register for these webinars, you're usually asked about your registration for whichever CADA and regulatory authority that you are covered under. And if you provide that, usually within 2 weeks, I think Kenyatta Hospital usually sends this, but maybe the organizers can respond to that. Now, the other question that somebody else is asking is, do we screen blood for malignant cells? The question is no, we don't. Because, but what we do is that when somebody comes as a donor, we put them through several checks to make sure that they are healthy. By the time you've got malignant cells in your blood, circulating in your blood, you don't look or feel healthy, and many times things are not healthy. So usually there's a questionnaire.
Evelyn, mute your mic.
Dr. Abdallah? Dr. Abdallah?
Yes, Irene.
Continue. I think there was some interruption from Dr. Evelyn. Continue.
Yeah, okay. I thought maybe she wanted to respond.
There is a question she will respond. There's a question she will respond shortly.
Actually, Irene, you should answer that question about screening for malignant cells. Why don't you handle it?
Okay. Let me go ahead. We do not screen for malignant cells. What we do is we screen for 4 TTIs, that is HIV, hepatitis B, hepatitis C, and syphilis. The policy we have currently in the country allows us to screen for the 4 TTIs, but that is not cast on a blanket that we are not supposed to do the other malignant cells and the other viruses and the other bacteria. We are able to do that if we find out that there is need for the populations to receive blood that has gone through the screening for these malignant cells and the markers. So currently we are not screening. That's the answer I can give.
Okay, can I just make some 2 additions? This is Dr. Nduko. I think the question on CPD, I believe that you have answered it fairly well, Dr. Abdallah. For all the participants to note that when you sit through the session, you then, the organizers, and I believe Dr. Thranira can speak to that, KNH will be able to send CPD points within 2 weeks. So, but I also wanted to speak to another question, which is the question of how patients can benefit from donated blood in the banks. I think the purpose of the National Blood Transfusion Service is to be able to provide blood to ensure we consider ourselves now, as we've been reforming over the last 1 year, a strategic enabler for you to be able to benefit or to be able to have access to blood. And therefore, in that case, I would say that if you have a patient, whichever hospital they are in, the hospital needs to make a requisition to the bank that is nearest. Most hospitals or all hospitals will know the nearest bank to them or satellite to them. The second point that I also wish to make is that we have been, as you will note, the online appeals that were very, very common have reduced. As the blood service, we look at the internet and social media every day, and if there are any appeals, we respond to them across the country, across board, and in an effort to ensure that patients are able to receive blood as needed when they need it, and blood that is safe. Thank you.
Thank you so much, Dr. Nduku, for that input. Asante sana, Daktari. So I'm seeing another question here on how do we disseminate the results of the TTI screen to the donors. KNBTS will always gives out results to the donors who are 18 years and above. This is because of the issue of consent. And we have trained counselors who are able to disseminate results to the donors, and we have a referral system that those donors who are positive are referred to our the facilities which we have identified, and those donors who are negative are told to come back after 3 months for every male and after 4 months for every female donor, and they join in. They are put in the system to be retained as blood donors. So we have counselors who disseminate the results to the donors. Those who test positive are referred, and those who test negative are retained. So unless we have any other burning question, I am seeing our time is over. Allow me, unless
there's a hand, Irene, from Rocky Jumapili.
Rocky from Kwale. Kindly use 1 minute to ask your question, Rocky. Mr. Rocky. Rocky?
He needs to unmute himself. There.
Rocky, we can't hear you. Kindly move closer to your mic. Rocky, go ahead.
Are you hearing me?
Yeah. Please go ahead.
Yes, my concern is how are we taking care of our regular blood donors so that they don't develop complications due to frequent blood donation? Thank you.
Rocky, can you repeat your question loudly? You are really breaking.
I think I heard it, Irene. He's saying, how do we take care of our regular blood donors from getting complications due to frequent donations?
Okay, go ahead, Dr. Abdallah. Go ahead, Dr. Abdallah, in a minute.
You want me to answer?
Yes, in a minute.
Okay. As Irene, as you've already just said, really, there's a recommended period between donations for men and women. And if we follow those recommendations, then the regular blood donors are not going to develop anemia or any other complication, because the bone marrow will churn out new red cells within the 120 days. And as long as the donor is eating a balanced diet and is healthy, there shouldn't be any complications that they develop. I think that's the shortest I can do.
Okay. Thank you so much, Dr. Abdallah, for that input. I believe Rocky from Mombasa, Kwale, you are able now to have that answer. Team, allow me to say thank you to the following people who have really managed to support and ensure that this webinar was a success. Dr. Nduku, head of KNBTS, and our CEO, for giving us the platform to be here today and be able to talk to many clinicians, the nurses, the CBTO, the satellite in charges, all the line managers and the regional heads, for giving us that platform to be able to be heard by the team and also to get feedback from them. Asante sana, Daktari. I want also to thank our consultant, Dr. Abdallah, who has always been there, not only as a mentor, but also supportive and also offering technical support, especially in the field of appropriate use of blood and blood components. Allow me to thank all the participants who have joined in, close to 400 participants countrywide, to ensure that this Zoom meeting was a success. Asanteni sana, and hope to see you soon in our upcoming meetings. Thank you too to Dr. Njogo from KNBTS, who has been our coordinator. Asante sana. I think all of us, we may live at our own pleasure. Asanteni sana.
Thank you, Irene.
Goodbye. Goodbye.
Bye.